This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, a senior attending in pediatric neurosurgery.
And I'm Dr. Alara, a research fellow. Today, we're looking at a fascinating new study from the 2026 edition of Epilepsy and Behavior. The paper is titled Seizure Outcomes of sEEG-Guided Surgery for Temporal versus Extratemporal Epilepsy in Children.
This is a timely piece of research, Alara. As we know, managing drug-resistant epilepsy, or DRE, in the pediatric population is one of the most complex challenges we face. When medical management fails, we turn to surgical options. But the success of those interventions often hinges on how precisely we can localize the epileptogenic zone.
Exactly. And that brings us to the core of this study. The authors aim to compare seizure outcomes between two specific groups, children with temporal lobe epilepsy, or TLE, and those with extratemporal epilepsy, which we refer to as ETLE. The common thread here is that both groups underwent stereo-electroencephalography, or sEEG, to guide their surgeries.
sEEG has really become the gold standard in many of our centers, hasn't it? For the residents listening, remember that unlike traditional subdural grids and strips, sEEG allows us to sample deep-seated or sulcal structures with a much lower morbidity profile. But the big question this paper asks is, does the location, temporal versus extratemporal, affect the ultimate seizure-free outcome when sEEG is the primary guiding tool?
That's the critical point. The study's primary goal was to inform surgical decision-making. In pediatric cases, the brain is still developing, and the presentation of ETLE can be particularly heterogeneous compared to the more classic TLE cases we see in adults. By comparing these two cohorts directly after sEEG-guided resection, the researchers provide data on what parents and surgeons can actually expect postoperatively.
Right. And when we look at seizure outcomes, we aren't just talking about a minor reduction. For these children with DRE, the goal is often Engle Class 1, complete seizure freedom. Alara, based on the study, how did the sEEG-guided approach handle the complexity of the extratemporal cases?
Well, the study highlights that while TLE often has more predictable pathways, sEEG is particularly valuable in ETLE because it allows us to map out the often elusive seizure networks in the frontal, parietal, or occipital lobes. The paper suggests that by using sEEG to guide the surgery, the gap in outcomes between TLE and ETLE might be narrowing, though the distinction in localization remains a key factor in surgical planning.
That's an important nuance. In the past, extratemporal surgeries often had significantly poorer outcomes than temporal resections. But if sEEG allows for more precise boundary definition of the epileptogenic zone in extratemporal cases, we are essentially leveling the playing field. It really reinforces the idea that the where matters just as much as the how when we're placing these electrodes.
And for the medical students listening, it's worth noting that the study specifically focuses on drug-resistant epilepsy. These are children who have tried multiple anti-seizure medications without success. The decision to move to sEEG is a major step in their clinical pathway.
It really is. The study emphasizes that the goal of using sEEG to compare these outcomes is to inform surgical decision-making. If we know that a specific subset of extratemporal patients has a high probability of a good outcome based on sEEG data, it might encourage earlier surgical intervention rather than continuing to cycle through ineffective medications.
Precisely. The surgical decision-making aspect is perhaps the most practical takeaway. It's not just about whether we can operate, but whether we should, based on the likelihood of the child becoming seizure-free. The data comparing TLE and ETLE outcomes helps us provide more accurate prognostic counseling to families.
So, if we look at the high-level takeaways, we have a comparative analysis of pediatric DRE, a focus on the precision of sEEG-guided surgery, and a clear look at how the location of the epilepsy, temporal versus extratemporal, impacts the long-term seizure outcome.
Exactly. It's about using the best technology we have, sEEG, to refine our understanding of these two different clinical entities in a pediatric population.
A vital study for any of us involved in the surgical treatment of epilepsy. Alara, thank you for breaking that down with me.
My pleasure, Dr. Aris.
And to our listeners, residents, students, and colleagues, thanks for tuning in to the Neurosurgery Hub podcast. We'll see you in the next episode.